And early, late, what?
I have cancer. There's a high probability that I will die from the cancer.
And early, late, what?
There are times when I'm scared, or when Janet is scared, or you go through a period of apprehension. It might only be for a moment, it might be for a day. I know that quite frequently I don't want to talk about it. I just want to be left alone.
Picture of my wife. She doesn't like it, but to me it has a certain appeal. I can see many of her.
It's sometimes very hard to understand that this is real, the reality of it. This isn't just a soap opera, and this isn't just going to go away. In fact, a couple of times, well, one time especially, I said, I feel like we've gotten on the wrong bus, and we're on with all these old people, and yes, it was kind of interesting. Oh, we made the most of this unfortunate experience, and so we've kind of gotten into it and talking to everyone about it, but now, all right, I just stop it. I am ready to get off. That was an interesting experience, but I want it over. And I want us to get back on the right bus and go back with the young people and the healthy people and where we really belong.
Have you ever talked to anyone who wanted to kill themselves or made a serious attempt?
Yes.
No matter how bad things get, they're going to get better. Now, they may not get a lot better, but they're going to get better if you have the patience and you're willing to commit the time and the energy. In all probability, I'm going to die, and not by choice. So what right do you have to sit there and say, I'm going to end it all? I mean, that's a real cop-out. It's not fair. It's not fair to the people who are living, but who know they're going to die.
So I think when they left our office after the initial visit, they felt encouraged in the sense that it was not, there was not a complete inevitability about what was going to happen. I think the fact that they realized then that this would not be a sudden life-threatening event where he would have to be all of a sudden rushed to the hospital or something like that, but rather, even if things did progress, that it would be a slow progression that they would have time to deal with and that we would be able to respond to rather than some immediate life-threatening complication. Initially, we felt that, in a sense, he would be like a model patient because he's an extremely intelligent guy. His wife is very intelligent. They have a good relationship. It seemed to have all the components for that aspect of it going very well. He asked all the right questions, paid attention, did what we were supposed to do, and they seemed to be able to communicate with each other very well, which we often find to be a very big problem. They seem to be able to communicate very well, but all these other complications, it was very difficult.
Can you see my scar?
Sure. I know, it's quite a scar.
Well, actually, it goes down further, too.
Yeah.
The first piece of surgery was just in through here. And they extended it down for the second one over and through here. And the discoloration you see is from the radiation. Same thing here.
You know, it's. I think it's always harder to treat somebody that you identify with, that you have things in common with. And as you said, he's a young man, and it's very difficult. It's somebody you share a lot of common experiences with, in the sense that you're the same age and so forth, and yeah, it's a difficult thing to do.
That has been tender right along.
This side?
I really don't know. You know, I can understand why, like right here, I'm not surprised that that would be tender, and I think that that's more the sutures than anything.
I was to the point where it was my impression where he was sort of dropping out of all decision making and he was not participating in his care, whereas prior, maybe 4 months before that, before the surgery, before he started having a lot of problems with pain, he was very much, I thought he was handling things very well. By this point, he had gotten to the point where he had dropped out of the decision-making process, and I felt that was not appropriate. I asked him at one point if he wanted to continue treatment, and he perked right up.
It was kind of interesting when Dr. Wyman let me in on having a choice. I had the set of mind that, up until that point in time, I had the set of mind that I really didn't have a choice, that I had to go through with this.
Yes.
It never dawned on me that I had a choice. Isn't that strange? You know, it's curious. The doctor said, you will go through chemotherapy. And I said, oh, okay, well, I just assumed then that I had to go through chemotherapy.
If he were having no trouble with the treatment, he'd probably stay on it and no problem at all. He's just really had a bad time with it. And actually, it was a good idea that he had it, and I saw how bad that was, because then I was supportive of him, too, deciding not to go with it anymore. It's just come down finally to quality of life. Emotionally, he wasn't dealing with it, and it just wasn't worth watching him go through that. And
He was post-operative, only a few weeks, and known to be free of gross disease, and yet had terrific pain, but not an abnormal physical examination. But he continued to have, and continues still to have, debilitating pain, not in the same area, but higher up in the abdomen, which has prevented him from returning back to work, and has really completely altered his life.
What was worse, having cancer or being in Vietnam and
Having
being
cancer.
exposed? In what way?
I know I'm going to die. And there was a lot of pain. I'm experiencing a lot of pain. And I am married, and I'm going to leave loved ones behind, and they know I'm going to die and so forth. So it's much more difficult with this. At least with, you know, in Vietnam, you didn't know. I mean, you accepted the possibility, but you did what you had to do. You'd rescue a downed aircraft, take care of the crew. You'd shoot people if you had to, and then you went back to your base, and you had a beer or a Coke, or you'd slice open a watermelon and eat. You know.
I'm interested in how you coped there. You know, a lot of people obviously began to smoke dope and things like that to make it easier. Did you ever do that?
Never did.
Not even dope?
No. Never touched the weed until I got back here to the States. And that was experimental. I've had less than one marijuana cigarette in my lifetime.
A lot of people tolerate symptoms for a long time, fortunately, because most of them go away. Most of the cases I see, the pathologic basis of the pain is a little more straightforward, most of the cancer patients. And the management of the pain has been inadequate. His case had a little different wrinkle because there was some debate among the medical staff about the underlying pathologic basis of his pain.
Demerol gives you a real nice buzz about 7 to 12 minutes after the injection. Gives you a very nice buzz, but it also relieves the pain. And with that first piece of surgery, I suddenly realized that I didn't have to live with pain. And in fact, the caretakers supported that. They said, look, you don't have to live with this pain. Don't be a fool. Take the Demerol. I took the Demerol.
Dr. Wyman was good. It's the other staff that really, one in particular made me very angry this last time when Ed went in, or time before last for some tests. The resident on the floor, I was sitting in listening while they were asking Ed all the questions and whatever. And then he walked out. I walked out to go to the elevator to go down, and he followed me out to the elevator and rode on the elevator down with me and said, well, you know, downstairs, I think it was downstairs, a lot of them think that this is just in his head, and he's becoming dependent on the drugs.
Oh, yeah, I'm sorry, I got to interrupt you. I can't tell you how furious, how mad I got, because if the pain is in your head, what Janet is about to say, or was about to say, did say, then whatever medication you're taking, drugs, you are building up a dependency on them. I was building up a dependency on the hospital. I was building up a dependency on the drugs. I mean, to listen to some of this stuff that was this garbage that was coming back to me, you'd think I was a damned addict. You know, I mean, I really got the feeling that that a lot of them thought, and correctly so, I guess, that I was addicted to, and I don't want anybody to think that of me.
This guy following me to the elevator and saying, well, what do you think about that? They think downstairs that he's getting dependency on the drugs, and it's kind of in his head. And I thought, who the hell are you?
I really get this feeling. They think they know you, in your case, better than you do. I know. Now, here we go again. Whether it's in my mind or whether it's physically, organically true is irrelevant. The point is, I know that Demerol, 75 milligrams with 25 of Visceral, I know that that combination of pain medication works better for me than anything. They have tried Dilaudid, even methadone doesn't work as well. Even taking methadone on a consistent basis does not work as well as the injection of Demerol. Even morphine doesn't work as well as the Demerol. I know this, I have experienced enough of it, and I'll lie there and I'll tell them this, and it's going in one ear and out the other. And it just really, really upsets me. Look, folks, I've been doing this now for probably as long as you've been practicing medicine, you know, in some cases. And I know my body, and I know what works. Damn it, let me tell you.
But that's also what's feeding what they were thinking, though,
Sure,
Edward.
of course.
You have a dependency on wanting a
I have-
shot of Demerol,
right,
and that's
right.
why you're in the hospital.
Right, which is as far from the truth. I admit that my ability to tolerate pain is not as strong as it used to be, but that doesn't mean that I am dependent on any particular drug, on any drugs.
You did feel that sometimes maybe Ed might be overdosing himself, or...
Yeah. Well,
Okay.
yeah, because all the other doctors thought that was an awful lot sometimes that he would have to take, or, yeah.
I don't want to be in a position of giving somebody, you know, more methadone or Dilaudid or something for what is really a psychogenic pain syndrome. And some of those dimensions are conceivable in people. I don't think there's any way to know that, certainly in one visit. Especially with people saying, this guy is an addict, he is preoccupied with seeking drugs as a way of avoiding the psychic pain of accepting his diagnosis, that this is really pathologic behavior and not inadequately treated cancer pain. That made things more complicated. I think what it came down to after the first meeting was my sense that it's impossible to tease out and do a psychiatric evaluation of a patient who's in pain, and that you have to address the pain first. I think I did tell them something like, I don't know if I told them I've never been unsuccessful, but I think in the vast majority of cases, or sometimes say 95% of the cases, at least my experience has been, you can really get significant pain relief with people. When you get down to thinking of the plight of the patient on the minute-to-minute or hour-to-hour level, it's overwhelming. And it's really unbelievable. Everything from the rides through the elevators to overhearing the gossip of the staff to the treatment that they do or don't get. I remember when I interviewed him, I wished I had a student with me because he displayed so many of the classic characteristics of the patient who had was having trouble getting pain medication. I remember one of the things he said was that when he told one physician that he thought he needed more, he wasn't getting relief or needed more medication, he was told, you're already on enough medication to stop a bear. And actually the amount that he was on was really not that much. I think there's good and bad clinicians in both disciplines. You might oversimplify it and say, well, psychiatrists would be, more understanding of the phenomenon. They should know more about the pharmacology of drugs that affect the central nervous system, etc. But it really isn't so. I think if we looked at our colleagues, that we'd find that there are some who are better at it than others, and the same with oncologists. I think first of all, you only have a chance to get good at what you do. If you don't do it, you can't get better at it. You need to actually get called in these consultations and take the risks of treating the people and have good and bad experiences that you learn from if you're ever going to get better.
I think in a lot of instances it was a matter of either misinterpretation or miscommunication. I think obviously we got sidetracked on the whole pain business too much. You know, I think we realized that a good while before he died. I don't remember exactly when we sort of came to this conclusion, but I mean, I think we spent too much time worrying about that. I don't know what the answer to that was. I don't even, but the thing that I think I learned from that is it doesn't matter what the answer was. That we should have done it the way that he wanted.
See, when you talk about pain, you know, there's the physical pain that that you can medicate. I have physical pain and it's medicated and it's taken care of. But then there's another kind of pain. Call it spiritual pain, where you can't medicate it. You can't make it go away. It's just there, and that's one of the things that happened in Vietnam, is that you see things and you experience things that you can't take 2 aspirin and go home and go to bed. The most painful thing for me to talk about Vietnam was one particular mission where only 2 of us survived, and I'm one of them. And the reason that those guys died, it was a waste. People ran. We were depending on other people, and they ran. And there were a lot of friends that died that day, and they shouldn't have died. Whereas it's easier to deal with cancer because of the support that I've gotten from
Do you think this experience is harder on a person like Ed, who has an illness from which he'll die, or on you, who must survive?
I would have answered without hesitation even a couple of months ago, me. But I don't know about that so much anymore because it's just been within the last couple of months that I'm really worried that this is going to drag out for a long time. And unless Ed starts feeling good, poor man is miserable. He's a good share of the time, and he just can't go on like that for a long time. And yet, see, I get to leave every day and go to work, and see, out of sight, out of mind. I mean, I do that. Sometimes that upsets me. I feel guilty for feeling that way. That not being able to say, oh, it's definitely harder on me. It should be harder on me, you know? I kind of feel like it should be, but I want to, because at least that'd be something that I could take, some of the burden. But now it's changing. It's changing.
Yeah. Jen and I are not having any problems. Thank God for that. And I thank ourselves too, because we put a lot of work into it.
But so the fact that he's able to tell her things and sort
involve
of
her
right, involve her, and even if it he says something to her that'll make her mad, still the fact that they've been communicating all along, then they can I think get over it better because she goes through a lot of things with him.
Mm-hmm.
I don't have any big desire to do a CAT scan right now. You feel good. You know now that when you're feeling good, you don't want any therapy. Unless you change your mind from the last time we talked about that. Then, if we do a CAT scan and find that the questionable masses are masses, or that the questionable masses are masses, and now instead of being 2 centimeters, they're 3 centimeters. We're not really going to do anything different anyway, right?
When would you?
Yeah.
Well, my feeling is, based on what we've said before, is that I would do something when you started to have symptoms.
Okay, but my concern is, as I recall, there were 3 abnormalities. The abdomen that was radiated, but then there was the pancreas, there was the pancreas and the rectal area.
Right.
I don't want those to get out of hand. I suppose what I'm saying is that if there has been a change in those areas, I want to know about it as soon as possible,
Well,
because wouldn't that affect, wouldn't
It depends on what
the
you
rate
mean.
of growth or whatever affect...
It depends on what you mean by out of hand.
I would want to catch it as early as possible so that we could treat it, I suppose is what I'm saying. Last Wednesday when I saw Dr. Wyman, I started out by saying, hey, look, I want to know because I want to know what my options are. And then the more we talked, he was making good sense. And it's true. Why at this point do I want to find out anything? There's nothing that can be done. I doubt seriously that we would perform any more surgery. If the abnormalities have in fact increased, why do I want to find out about it? There's nothing that can be done. So I'm really confused at this point as to what I want to do.
So on the one hand, I don't want to come out and say it doesn't really matter what we do at this point. But also, I don't want to give him the feeling that there's some reason why he has to keep going through all this.
Yeah.
Because there really isn't. If it doesn't matter when we find these things, we'll find them, and there's not much that can be done about it.
But right now he can't give very much, and he does, and he's constantly thinking about me and telling me how much he loves me and whatever, but it's like I went to Memphis for 4 days, and he could say as much to me over the phone as he does at home, because he hurts so much of the time. He's so uncomfortable. He doesn't feel like hugging and as much as we used to. Now he likes me to sit next to him, and and he likes to touch me, but he just doesn't feel like getting even very close to hugging, and so there's just not much giving back at all.
Whenever you get run down and whatever, if you're in pain and just very uncomfortable, hell, you're not going to want to go to bed and make mad passionate love. You're going to want to take care of yourself. It's like an animal crawling off into its cave and licking its wounds. You're concentrating on trying to get better. You're not concentrating on trying to make love and helping your mate attain orgasm. That's the furthest thing from your mind. I know that there's going to be a period of remorse, and that we do depend on each other quite a bit. We have a very strong relationship in that regard. So I can understand perhaps the loss of that relationship might prompt her to want to
A
take
shock,
some
because I had it all played out in my head that the minute we understood that it was getting bad, I thought we'd at minimum have 2 months. What happened to the months? On a Monday, the surgeon walks in and says, if I could say days, it would be weeks. I could say weeks, it would be days.
You were 15 when your brother died, and your brother then was about 21? What had happened to your brother?
He went to his 21st birthday party and was coming home and had a car accident.
Was killed immediately.
Yeah.
How did you feel then? What was the impact of that crisis on you? Did you?
I think the one thing that I remember the most is that, and it's so classic, you see it in movies and everything else, is that I never really told him I loved him. And that just devastated me. I mean, that part. There were things I wanted to say to him.
You're really angry.
I am very angry.
What?
I really thought before, I'm always going to be, in the end, I'm really going to go to Dr. Wyman and to all the nurses and say thank you. Oh, and thank them, because they've been so kind and caring, and they tried so hard. And in the end, the patient died, so what did they really do?
no matter how many times it happens, no matter how many times you're exposed to it, it has to be the experience that has more impact on a person than any other, to be in the presence of someone who's died. And in particular, if it's somebody that you can identify with.
I don't think one person can treat any of these patients. I think the needs of patients like this are complex and multidimensional, and that it doesn't always work out that the primary physician, if it's the oncologist, can meet all those needs. Sometimes they can. It depends on the needs of the patient. And sometimes they can't, and it has to do more with the needs of the patient often than with their own skills and abilities.
Had Dr. Goldberg not come in, done what he did, which was come in the day after his surgery that Tuesday and go over all his charts and make all these adjustments, changing. Ed was completely delirious and hallucinating and everything.
I didn't really know what I would find when I got there, and what I found after his surgery was that he was 4+ delirious, and was just didn't recognize people, didn't know what was going on. His wife was very distraught about not being able to make contact with him, and my reaction to those things is I get into an automatic pilot at that point, because so often on the consult service we see post-operative delirium and delirium of multifactorial etiology, that I have a program, more or less, to carry out, and I look for anything correctable, and let's see what's going from there. And in his case, what was correctable was switching him off of a Demerol drip onto a morphine drip. Occasionally, people get delirium from any of the narcotics. Sometimes they do better in one than the other. In my experience anyway, it's a little more common with Demerol than some of the others. So I thought, we have nothing to lose. We'll give them an equianalgesic dose, and maybe that will help. We often use adjunctive Haldol or Navain because the neuroleptics seem to tamp down some of the agitated behavior and help the brain organize and process information a little more. And then we addressed all the usual metabolic issues, like small things like oxygen. You know, a little more oxygen going to the brain never hurts.
What did you talk about that you wouldn't have been able to talk about had he maintained a confusional state from?
Oh, well, Ed completely, within those 5 days, completely went through all the transition of realizing he wasn't going home. This was the time he was going to die. Helping me, saying everything to help me make all the decisions, to get all the financial things in order. He planned his own services. He said things about what he wanted done about certain things, all those kinds of things, which sure are just nice to haves, but damn nice to haves when it's the last thing you get. And just being able to tell me how much he loved me, and for me to be able to tell him, and for us to talk about my life after him, our life, how it had been, to talk. We weren't able to talk that first day or two after surgery.
At least this wasn't a problem. It could have been a lot worse. I mean, we have cases where, as you know, the oncologist will not allow the patient to see me, or will reject any recommendation I make, or not allow me to write prescriptions, or will put the patient in the middle in an impossible situation in which they sort of give the patient the message, you got to choose. You know, it's not much of a choice at that point. But fortunately, none of that happened.
I always thought, I guess I just wasn't listening to you or something, I don't know, but I always thought I heard you say, whenever I asked you questions of what's going to happen, there were 2 or 3 times I asked you that, and you said, well, There'll be plenty of time for that. I always thought I'd have at least a couple of months warning.
Those things are just hard to predict.
Not just 1 week. And I didn't know that the last time we left that house, he would never come back to that house. What happened to, there'll be plenty of time for that.
Again, to me, I think people tend to think that if even something as terrible as death, if you can only structure it, if only you can sort of set the stage the way you want it to be set, then it won't be so bad. And to have, to say, well, now if I, 2 weeks away, I'm going to act a certain way. And 4 weeks away, I'll act a certain way. And, 6 months away, I'm going to act a certain way. And, I think it's just an effort to try to make this not so bad. If only you can do it in, the way you think it'll be good, it won't be so bad.
And it won't.
But see, in my opinion, it doesn't work. It's still bad because if you can set the stage down to the last detail, but one footlight is burned out, that's what you're going to remember, because that's the thing that will take your mind off of the fact that he died.
I don't agree with you.
Well, I know.
Because I know it sounds like I'm concentrating on what's bad,
Yeah.
but that's because I'm here with you and I'm getting
Yeah.
this chance.
Yeah.
And so I'm concentrating on the negatives to try and process them.
Believe me, I agree that there
But the
were a lot of
positives are what
negatives.
makes it okay for me, because I did get that last week, and I got to structure it, and it makes so much of it okay with me, so much of his death okay, because I got to spend the last 5 days with him, staying in his room with him at night. We had said to each other everything we could want to say to each other. So many things were perfect about it. And that's what makes it okay for me. That's why I think...
Just imagine yourself 150 miles an hour, and there's a wall coming up, and you manage to miss that wall by 2 inches. Imagine the exhilarating feeling you have when you step out of that car after you've stopped it. Whoa, look what I did. I came that close to ending it all. But here I am, folks, alive, whole, in one piece. There is an exhilaration to having flirted to come so close to death as to be bleeding from an exterior source. Somebody shot me, but I'll go to hell, I'm still alive. Something injected this cancer, but I'm still here, you haven't got me yet. There is an exhilaration to that. There is a challenge to be able to overcome the most inevitable of all man's experiences, even for just a moment, to overcome that ultimate end, death.